looking at different regulation and breaking it down, but getting to speak with people who are living inside of these shifts professionally and personally. My guest today is Dr. Kimberly Chernoby. Kimberly is an emergency medicine physician, a reproductive health lawyer, and currently serves as Chief Operating Officer and Chief Legal Officer at femInEm. We met several years ago in Washington, D.C., when she was serving as Health Policy Fellow on the Senate Health Committee. It was definitely an intense year. She ended up inviting me to go protest outside of the Supreme Court during, I believe it was the initial arguments for Dobbs. So cold that day. But she's done just so much work. She's doing conversations with universities and other organizations that are looking at advancing reproductive rights and access. And I really wanted to have her on today to discuss the really powerful article in the New England Journal of Medicine, examining the conflation of contraception and abortion and what happens when these definitions begin to move in law and regulation, and then how it trickles down to public rhetoric. Before we get into the article itself, I do want to make sure we're really starting from the same baseline. What I hope to do with my platform is make the wonky, perhaps policy and legal side more accessible to everyone so we can all understand kind of the environmental place we're in currently and the big regulatory levers that are impacting this article. Um, so, Kimberly, I'd really like to start by zooming out just slightly with your article and talking about the Mexico City policy that you discuss, sometimes called the global gag rule. And it's something that you mentioned changes depending on who occupies the White House. For those who may have heard the term but don't fully understand the work, can you walk us through what the policy actually is and what it does?
Yeah, sure. So when we think about laws in the United States, we often think about Congress as the body that passes laws that govern what we do. But in reality, there's a whole body of law called administrative law, which is law that's passed through the rules making process. And that's all done through the executive branch. And so, as we know, the executive branch is headed by the president. And so that means that anytime the president changes, a lot of administrative law is subject to change. And one of the rules that we see change with every administration or most administrations, is the global gag rule or Mexico City policy. And so, what that policy says is if you are an international organization that receives US funding, let's say you're a nonprofit in Kenya and you get, USAID, well, or other global funding, you can't get that money if you talk about abortions with clients or do any sort of referral to abortions. And so the global gag rule, the name comes from the fact that it is a global gag on abortion counseling and abortion services for orgs that want to receive US money.
Got it. Got it. And I guess I'm just kind of curious, what is the repeated reversal tell us about how reproductive policy moves through executive power? Um, is there any specific trends that you see during the turnover of administrations or any trends?
I mean, so when the executive branch changes leadership, right, when there's a new president and a new administration and it turns from Republican to Democrat, it's very reliable that there's like a suite of laws that will change every time. And so that includes, rules about funding to Title 10 clinics and things like the global gag rule.
Got it. Got it. And then I know that you've been operating within the administrative law, and it definitely feels very technical. But can you kind of speak to, I guess, how the administrations translate these regulatory shifts into actual policy or legislation? Or, is it an executive order where perhaps it doesn't have as much teeth or standing, or is because it's so easy to undo since it is, just by one branch bringing it over? And then, how does this impact even when Congress hasn't passed new legislation? For those perhaps aren't as familiar with regulatory environment, how things become a law.
Yeah, so administrative law moves much more quickly than Congress because when we're talking about passing, so legislation refers to lawmaking by Congress, not in the administrative law world. Legislation, I mean, you're talking two chambers, you're talking 60 senators, you're talking veto powers, right? Like that is a long process. And so that is why you don't see a lot of meaningful legislation moving, especially not quickly. Administrative law, on the other hand, right, it's executive orders, it's going through public rulemaking where the administrative branch will say, "This is the rule that we are proposing. It's open for public comment." They take the comment, they address all the public comments, and then they issue their final rule. And so because you don't have that same, system of checks and balances within the branch, that exist over in the legislative side, it's just a lot easier to move things with the administrative law world.
Yeah, great. Thank you for that clarity. I think there's a lot of misconception on executive orders. Generally, the easier it is to just, sign something with a pen to become a law or an executive order, the easier it is to reverse it. And I think a lot of people don't quite understand that distinction between going through the chambers, going through committees, all that kind of processing.
Yeah,
Um,
it is a lot easier to reverse them, but for the duration of it, being in effect, it has the effect of law, right? And so just because it is easier to undo doesn't and so for example, if a Democrat were to take the White House in a couple of years, we would expect the global gag to be repealed, but while it's in effect, it has the full force of law.
Yeah. Yeah, no, that's definitely an important thing to, keep centrally as we start looking at some of these executive orders, EOs, and this administrative law. And then really before we get into the article content behind writing it, I really want to talk about Title 10. And I want to discuss because it's referenced a lot in media, but I don't really think there's quite a foundational understanding of what it actually does, who relies on it, and, how it really practically can impact things like, say, family planning. Would you mind giving just kind of like a, high level understanding of Title 10?
Yeah, so Title 10 clinics are federally funded clinics. It's the only federal funding program that is exclusively focused on family planning, right? So we think of Medicaid as also a big funder of family planning services, but Medicaid obviously is much broader. Title 10 clinics exist to support family planning and to make it affordable and accessible to our communities. It's been around for decades, but more recently we have seen it become more political. And so but when you think of Title 10 clinics, so any there the clinic will not say Title 10, right? Like, there are clinics that receive money from the Title 10 program, and those are Title 10 clinics, but it includes things like, some Planned Parenthoods get Title 10 money. Sometimes it's distributed through health departments. So there's lots of different avenues that clinics can exist. Title 10 clinics cannot use federal funds to do abortions because of rules like the Hyde Amendment, right? So the conversation is not about whether Title 10 clinics are using Title 10 money to do abortions. The conversation is more about what other strings is the federal government putting on the money that goes to Title 10 clinics. Usually they're doing things like pap smears, birth control, even prenatal care and that sort of thing.
Yeah, and, just to speak to, the Medicaid and its incredible impact in family planning, I think as of last year, I know we've kind of stopped collecting the data, and I have not kept up with ACA and Medicaid enrollment this last fall, but our most recent information showed that 40% of all births in the United States are supported by Medicaid funding. So this is massive. This is a huge, lever for getting funding to people giving birth in our country, and just family planning in general.
Mhm.
So I guess being just into your recent article, which we had kind of spoken about this prior to you officially writing it and having it published. And when you told it to me, I was like, yeah, she's a genius. Like, this is such a good insight. I think right now I'm seeing content being created about how they are coming for contraception. And, you get Comstock Act thrown around a lot, which is, how we monitor what goes through the mail, specifically as it pertains to abortion medication, mifepristone and misoprostol, being able to prevent that from being mailed via telehealth, kind of like a prescription. But your article titled Conflation of Contraception and Abortion Implications for Access to Contraceptives looks at something that really seems technical on the surface, but it's very structural and very, like, I think, insidious. And I really appreciate you publishing this. And you argue that when legal definitions kind of begin to shift, even subtly, and how we look at the definitions of common phrases, they can reshape funding, coverage, access in ways that may not be even immediately visible, but kind of set the foundation for different legislation to come down the pike. At a high level, what prompted you to write this piece, and what concern were you seeing emerge?
So I've been following attacks on birth control for a while, right? And they've been going on for years. We've seen it as early as Hobby Lobby, right? Oh, we don't want to, certain employers saying we don't want our insurance to cover birth control because we think that they cause abortions. We've seen members of Congress go on the floor and in the congressional record, call things like Plan B abortifacients and argue that Plan B causes abortion. We've seen state houses exclude IUDs from insurance coverage because they think IUDs cause abortions. We've seen the Students for Life for America say that all hormonal birth control, which would include daily pills, patches, rings, as causing abortions. And so the idea that people are calling certain forms of birth control abortion is not new, but we hadn't heard it from like the highest levels of our federal government, right? Like we've heard individual lawmakers say it, we've seen it in state houses. Um, but seeing it at the federal level is what really raised my interest in like, okay, what's next, right? And so, going back a little bit, there's obviously Project 2025, and this was this blueprint of, oh, these are policies that the current administration might take, and some of it includes excluding certain forms of birth control from the ACA birth control benefit or making them inaccessible. Then we have this giant stockpile of birth control in Belgium, right? And so there's this huge stockpile of birth control. It's meant to be distributed across the globe to help global and international family planning efforts. Um, USAID is no more. And so then there's a question of, okay, well, how are we going to get this birth control out? And then the federal government just says, "Oh, we're just gonna burn it," right? Like, and we're not talking birth control that's expired. It's birth control that is still good, that could do a lot of good in the world, and they say, "We're just gonna burn it," right? And so you have other organizations, other countries that come in and say, "Well, we'll just buy it from you and we'll distribute it ourselves if you really, for whatever reason, are so opposed to distributing this birth control." And the administration says, "No, we're not going to let you buy it. We're not gonna let you take it and distribute it. We are going to burn it because we don't want it to go to anyone." And going back to the beginning of our conversation, the reason they cited, right, was the Mexico City policy saying, like, we don't support using federal funds to promote abortion overseas. And we are calling this birth control abortifacients. We are saying that this birth control causes abortions. And so for that reason, we're not going to allow it to go abroad. And so that's the first time that I really saw the federal government adopting this argument in policy that some forms of birth control cause abortion. And it's a very slippery slope because of all the other rules and regulations and laws that cover abortion care through the federal government. And so if they start extrapolating those to birth control, then you're really looking at extreme limitations on birth control. And so that's what inspired me to write this piece.
Yeah, and I think that's really important that you're really identifying how important that definitional line matters so deeply, both in medicine and, statutory interpretation. We have precedent founded on these definitions. And to that end, what I really specifically loved about the article that you posted was the section of your piece where you discussed the distinction between pregnancy beginning at implantation versus fertilization. Can you, speak to how ACOG um, defines it versus perhaps the law and that, variability?
So the beautiful thing is that ACOG and the law define it the same because there is an accepted definition of pregnancy, right? And so HHS regulations, which is the only place right now where there's a federal definition of pregnancy, and ACOG both define pregnancy as beginning at implantation. And for your viewers who are rusty from Bio 101, right? So you have an egg that is released during ovulation, and then sperm meets the egg in the reproductive tract, usually in the fallopian tube. Then you have a fertilized egg. But at that point, there's no detectable pregnancy. That's not pregnancy yet. It's only when that fertilized egg travels down the fallopian tube into the uterus, into the body of the uterus, then implants in the wall of the uterus. At that point, when you have implantation, your body starts secreting something called HCG. And that's the hormone that we track for pregnancy, right? So if you pee on a stick or you get a blood test for pregnancy, what it's measuring is your HCG levels. That hormone is only produced after implantation. And so, for a myriad of reasons, that is why pregnancy is defined as occurring after implantation, partly because that's the only time that we have a clinically detectable pregnancy.
Yeah, and, uh I think it's so important to understand these legal definitions when things are determined certain things. We have established precedent. So when these words are used, it's not arbitrary. There's a purpose. And it really creates a lot less confusion. And what I'm seeing online and from a lot of people who are more in that mindset of like the Maha movement, they're speaking more to the detriments of birth control. I'm seeing a lot of unfounded rhetoric. I haven't seen any studies that really was overwhelmingly convincing that this was harmful or should be reviewed by the FDA, on my end. And I've spoken with providers throughout the South in what a little abortion clinics we do have down here, where they have to combat misinformation constantly. Can you do you have any comments on how these subtleties can fuel misinformation, especially misinformation when it comes to the health side?
Yeah, I mean, I'm not gonna go viral for talking about birth control, and neither are most OBGYNs or ER docs or family medicine doctors or primary care, whoever, pediatrician. Like, the doctors are not who are going viral, right? And there are even studies that show that the content that goes viral about birth control is more likely content that focuses on the negatives, right? But, like, it's not that they're evidence-based, it's just that people I mean, the plural of anecdote, right, is not data, but people have anecdotes and they present it as data, as the truth. But that's what people want to hear. And, it's kind of novel, right? Like, oh, what is your doctor not telling you? So that's what's going viral. I think because people feel like, oh, is this being kept from us? And I don't know. I mean, other than just continuing to state the truth and rely on science and facts and evidence, like, I don't know what we as physicians or the medical community can do to get the same kind of perch that, MAHA movement and others who are kind of, like, harping on these supposed harms of birth control can get.
Yeah, and, previously last week in the, Senate Help Committee, there was, the first, interview with, s you know, a with Casey Means and her speaking to, perhaps how it's harmful and things like that. That narrative really is not helping the movement of science and evidence-based policy and access to care. Um, I think we touched about it earlier in the Hyde Amendment, which you had mentioned is prohibiting any federal funding for going to abortion care. I know it gets tagged on a lot. I mean, you saw this all the time in legislation that really had anything to do with health. I know when we were looking at public health emergency and Operation Warp Speed legislation, there would always be some inclusion of the Hyde Amendment added to that document. I mean, I see it tacked on to a lot of different health that really, it doesn't have any relevancy, but, whenever health funding is appropriated. Can you speak about, how that possible, conflation of abortification and birth control could impact patients in the Medicaid system, patients in the VA, or patients in the Indian Health Service. If we were to, kind of start implementing the same ideology and thought process as with the Belgian birth control.
Yeah, so that's like the crux of the article, right? And so the Hyde Amendment is a rider that goes on spending bills that says federal funds cannot be used for abortions except for in very narrow um, instances like rape and incest. And so the concern that I have is if they expand this reasoning that they use in Belgium, right, that some forms of birth control are abortion and so should be subject to the same laws, then you could see the incorporation of birth control into these policies, right? And so if Medicaid money can't be spent on abortion care unless it's for rape or incest, the hypothetical is that they will also say Medicaid money can't be spent on whatever forms of birth control they deem abortifacients, right? Or that those things could no longer be provided at the VA in the same way that abortion care is not provided at the VA, or that they couldn't be provided through Indian Health Services. And so that's the real concern, right? Is that you stop having access to the whatever forms of birth control they decide to arbitrarily label as abortifacients.
Got it. Um, is there any federal policy legislation that you've seen that could perhaps help support access to contraception? I know right now, because things are so, let the states decide, we're seeing a real patchwork. Is is there any conversation at the federal level that could possibly give us some hopes? I know there was the Reproductive Rights Act, I believe in 2022, that looked at protecting birth control outright. I don't believe it made it out of committees, but I would love to know if you have any insight or know of anything.
Yes, I think you're talking about the Right to Contraception Act, which is a bill that would codify the right to birth control. So stepping back, we always think of Roe as the Supreme Court case that protected the right to abortion. Similarly, there's Griswold, which was the Supreme Court case that recognized the right to birth control. And as we saw with Roe, anything to the Supreme Court, right, is subject to becoming undone if the Supreme Court decides to reverse their precedent. And so the idea is, well, Congress could pass a law saying the same, and then it would protect it despite whatever the court says. So if there had been a law that said Roe, was had the same holding as Roe, then even if the Supreme Court had decided Dobbs, there would be, statutory protection for the right to abortion. That bill is called the Women's Health Protection Act. So on the birth control side, you've got Griswold in the courts, and then in Congress, legislatively, you have the Right to Contraception Act. That bill has actually made it out of committee and has made it to floor votes in the last couple of years, but obviously it has not passed because it would need 60 senators to vote in support of it. And so that would be the bill. But even then, right? So you have a Right to Contraception Act and it says, okay, like let's say it passes and it says you have a federally protected right to contraception. Well, what happens when they say, okay, but this form of birth control is not actually birth control, it's an abortion. So I'm not sure how much that would protect the individual forms if the argument is that they're not birth control, that they're actually abortion. What would be really powerful would be if there is some sort of legislation that adopts the scientific definition of pregnancy as happening with implantation. Because like I said, right now it just exists in regulatory code.
Got it. And last year I really felt like there was a lot of more conversation. I mean, now there's other competing legislation and policy, things happening right now that's taking more of a priority. But I felt like last year there's a lot more conversation, and I think worrying on the side of advocates and reproductive rights organizations that were concerned about revoking access like over the counter, even like a plan C type situation. And over the counter access to these, I'm sorry, not plan C, to plan B rather. Sorry. Um, are we still seeing any maybe like legislative efforts to, make that happen or revoke access to over the counter prescriptions? Or is that, kind of now fallen by wayside with a lot of the conversation with access to abortion medications?
Yeah, I haven't seen much, in terms of attacks on over-the-counter existing over-the-counter access to birth control. Partially, I mean, that would have to go through FDA, right? FDA is who decides what is over-the-counter and not. Now, can states or retail pharmacies impose their own restrictions? Sure. But generally, that would be through FDA. The other thing is, like, birth control is super popular, right? People believe that people should have access to birth control, um, and so I think we're seeing that legislators understand that attacking birth control is not popular, and so that they're kind of backing off on attacks on birth control, at least outright attacks, right? So they're not gonna say, "Oh, we're gonna ban birth control." Instead, they're just gonna covertly say, "Well, that thing is not birth control, that's an abortion, and so we're just gonna call it an abortion and regulate it like an abortion."
Okay, got it. Yeah, thank you for that distinction. And, um, the majority of Americans do support access to birth control. They also support access to abortion medication and abortion medical care as well. It is still very popular, despite what I think a bunch of very loud voices are saying. Overwhelmingly, those things are popular. Um, I want to pivot just a little bit. We've talked a lot about courts, legislation, agencies, things like that. But you also are a practicing emergency physician. And at some point, I genuinely hope that you get a masterclass episode. I am incredibly impressed at the educational attainment that you have, but also how you juggle it all while also being a great friend and showing up as a mom. So drop that masterclass soon, hopefully.
I'll have to find time.
Right. Put it in the calendar. When legal definitions begin shifting in the background, what does that feel like inside of clinical practice?
It feels, like, very real, like, these are not abstract thoughts, right? Like, even, clinicians I've worked with who are very firmly, in support of abortion access and reproductive health care will say, "Oh, do I need to get a consent form for Plan B?" And I'm like, "No, Plan B is not an abortion. Plan B is birth control, and we do not need signed consent for birth control." But it's just, like, it is so insidious, the conversation that, "Oh, Plan B, abortion, medication abortion." Like, as if that they are on the spectrum of the same thing or the same thing, it really just gets in the corners of everyone's minds, and I think the whole point is, right, to lead to this confusion. And so, and even with patients, I offer them Plan B. Let's say someone comes in for a retained condom because the condom, got dislodged during sex, like, that is a case where I should be prescribing Plan B because they've had a failure of contraception, and they're like, "No, no, no, I don't want an abortion," and it's like, "No, I'm not offering you an abortion. I'm saying that you need backup birth control because your primary method failed, and this is, like, the perfect indication." And they're like, "Oh, okay, I understand." I'm like, "You're not pregnant." I mean, I don't you might I mean, if you're pregnant, it's not from the sex that you were having 3 hours ago, right? And
Yeah.
so and, like, trying to explain to them, like, that what I'm trying to do is birth control. But, I mean, that's the whole point, is to conflate the 2 and to cause this confusion. And so I encounter it all the time in clinical practice.
And what's so striking to me too is we're seeing a lot of people, no longer able to have Medicaid access. We're seeing such a reversal of just access. I'm gonna speak specifically about the Southeast now. Access to clinics geographically, we have a lot of obstetric deserts here because there is such a gray area. We're seeing obstetricians, gynecologists leave this area because they aren't able to train to the fullest extent and, practice under their board here. And there are very real penalties to practicing medicine here in this region. And just to emphasize that emergency rooms and emergency physicians are at now ground zero of administering birth control or having conversations about it. And I really think that sets the conversation up to talk about feminem. We're seeing and the incredible opportunity that they're seizing to improve how patients receive care. Just very briefly, the one big beautiful bill, the reconciliation bill that passed, I believe, like July 1st last year, which is kneecapping access to healthcare. We're going to see it impact greatly in rural areas as well. We're already feeling the impacts of that by seeing birthing centers that were in the process of construction being halted and funding reversed, more so of like bracing for impact. And as we see more of these, clinics and more hospital consolidation, emergency med is the forefront of this care. Can you kind of give a little bit of insight into how femInEm is, addressing this new, I think it's just maybe perhaps not new, but an amplified need?
Yeah, so the healthcare system loves to rely on emergency departments for anything and everything, right? I was working a shift last week. I remember I had 4 cases that I sent to interventional radiology. And he was like, "Why are they all coming to the emergency department to have this procedure done?" I'm like, because where else are they gonna go? Do you think that you are scheduling in the next week, right? And if they call you, they're gonna schedule a month out, but if they show up in my ER and I call in, then they get it that day, you know? And he just couldn't believe it. And so it's not just Repro, but Repro is no different, right? When patients don't have access to care because there's no OB clinics or because there is one OB clinic and they're scheduling 3 months out and they need care today, the emergency department is the place that's open 24/7, 365. We'll see everyone regardless of their ability to pay and we'll take care of any and every single complaint. And so it has become incumbent on us, especially, in the wake of DOMS and the closure of reproductive health care facilities across the country, that we increase our capacity to take care of patients who are here with reproductive needs. And so that means everything from prescribing birth control to managing miscarriages and pregnancy complications.
And there's something you said in that answer that I do kind of want to pull out and discuss. It's a gray area that I myself am confused about. I have always been looking at EMTALA protections um, in the wake of the abortion, trigger laws that we saw in the South, where once Dobbs was passed, we immediately saw Southern states enact 6-week abortion bans or, really, really roll back a lot of access and then not be further chipped away at the state legislatures. But EMTALA, and please step in if I misspeak, protects people without the ability to pay to still come in and receive care, preventing them from being turned away for any reason where they're still in critical condition. And I believe it was last year, there was such a flurry of legislation that now, like, everything, even like Pearl versus HHS, I'm like, was that even last year? Like, it feels like so long ago. But we saw kind of this start of delineating reproductive medical care from EMTALA. Can you speak to how they're they kind of, wanted to prevent EMTALA from protecting these patients?
Yeah, so EMTALA says that everyone who presents to an emergency department, regardless of your ability to pay, regardless of anything, you are entitled to a medical screening exam, which means that someone has to look at you and decide if there is an emergency medical condition, and if there is an emergency medical condition, to offer stabilizing treatment or to transfer you to somewhere where you can receive that treatment. And so that means that if you come into the emergency department and you are pregnant and you are bleeding, and someone does a medical screening exam and they establish that you have a condition that can only be stabilized by an abortion, then the stabilizing treatment required by federal law is that you have emergency abortion care. And so this came into issue when states started passing these abortion bans and said, oh, no, you can't treat these patients with abortions. You just have to let them sit there and wait until they are bleeding to death. And then you can intervene, but it might be too late at that point. And so it went all the way up to the Supreme Court. And essentially, outside of Texas, it's very clear that EMTALA supersedes abortion bans. And so if someone has an emergency medical condition and requires an emergency abortion to stabilize them, then that's the care that they're entitled to receive, regardless of the state law.
Yeah, yeah, there that uncertainty of about where federal emergency care obligations begin and end, especially in states with restrictive
Mhm.
abortion laws, in that gray area, whether intentional or not. Just physicians worried about their own boards on the line can lead emergency physicians to hesitate or undertreat out of fear of legal exposure. And I think when we hear about individuals who are, returned and said, please come back to the emergency room once you experience XYZ or once you're septic, or we're hearing people in parking lots. There is such this legal area where, you know, in real time when you're administering care and you aren't an MD/JD, you don't understand what you
But that's the thing, right? Like, so this the gray area actually doesn't exist. In every state, it is legal to take care of patients who have ectopic pregnancies and miscarriages. The There are governments that are trying to create confusion and to suggest that there is a gray area, but the reality is that no. And as emergency physicians, like we've trained our whole lives to know how to manage these patients and to save their lives. And so that's part of what femInEm is doing right now. So we do a number of things, but one of our biggest efforts right now is getting out to emergency departments across the country to explain to them that no, as ER docs, it is within our right to treat these patients. It is legally protected care, and we know what to do for these patients, and so we should be doing it for these patients. And there should not be stories of ER docs discharging patients who have an ectopic or who are bleeding and unstable from a miscarriage.
can you, I guess, as a part of that educational component, can you speak further more on the education side that emergency med docs get when it comes to, birth control, reproductive health care? Because my understanding is that femInEm really tries to address any gaps in that, and empower physicians to support their patients.
Yeah, so I mean, in training and in years past, there hasn't been a big focus on initiating contraception. And I think part of it was, oh, that's a primary care issue where people can go to their OBGYNs. But the reality is they can't, right? There are not OBGYNs to go to, or if there is, they can't get in quickly. And just like we refill medicines for diet, it's not even just refills, right? I start medicine for high blood pressure. If I make a new diagnosis of diabetes, I start new medicine for these patients. And so unwanted fertility is no different. If a patient comes in and they have unwanted fertility, then it is very much within our capacity as ER docs to initiate contraception. Um, and more important now than ever with like the closure of OB clinics, with reduced Title X access, with reduced Medicaid funding for family planning, and with just generally the state of the world. And so it's something that we can do, but a lot of ear docs maybe don't feel comfortable doing it. And so femInEm, we have on our website, if you go on our website under resources, there is a whole section on how to initiate contraception in the emergency department. There are free CME videos that docs can watch that they feel comfortable doing this work. We are working on research to kind of show that this is something that can be done in emergency departments and is sustainable. And I think, I get it. ERs are busy. Our wait times are going up. We are crowded. We have patients boarding in hallways. And so it's like, oh, is this just another thing added to our plate? But this is something that doesn't take much time. And these are patients who are usually just getting discharged anyways. And so it's not like, oh, by adding, contraception counseling, I'm going to add another patient who's going to board in the hallway for 18 hours. So we do that. And then with regard to miscarriage management, the teaching has just changed. And so before, a lot of us were taught that expected management was the way to manage these patients. If they come to the emergency department, they're having a miscarriage, just send them home and tell them to follow up with OB. But the standard of care has changed. We now know that they do better if we offer medication, specifically mifepristone and misoprostol. And so as ER docs, we should be practicing evidence-based and up-to-date care. And so now that the recommendations are different, we should be doing something different. But how are ER docs getting that information, right? Like they're not getting practice bulletins from ACOG that say, oh, here's our updated guidelines for management of first trimester bleeding and pregnancy loss. And so we at femInEm have taken it upon ourselves to make it our job to make sure that docs know so that they are providing the best care for these patients that they can.
I absolutely love to hear that. And when we were talking, I'm like, I need to circle back with you offline and get femInEm to a few hospitals down here in emergency departments, because I have been speaking with a few EM physicians as well as I'm trying to get, the word out, especially as it pertains to crisis pregnancy centers. A lot of EM physicians are referring unknowingly without any, ill intent to maybe a crisis pregnancy center because they perhaps just don't have the time to look into that care and believe that they're
Word of advice to any of these docs you're encountering, if you go to ineedana.org, you can find a list of all credentialed abortion clinics so that you don't accidentally, refer patients to CPCs.
yeah, and I love that you're shouting out that resource. It's a lot of what I'm talking with providers about, in emergency meds here locally, where I'm at, but it should be almost like a continuing education credit. You know, a lot of I mean, every physician needs X amount of CEs to maintain their board standing. I think it varies by specialty, you know, all you can get CEs through various different webinars or
You can come
conferences.
to the femInEm website and get several of them for free, not just on birth control, but on ultrasound, ectopic management, pregnancy of unknown location, early pregnancy loss. We got it all.
See, I am so grateful to Platform, the organization that you're with, because there is such a confusion, and I think now a lot of emergency med providers at various levels are seeing more patients coming in, and I think just as an aside, the website, that, you know, talks about how to manage your abortion on your own terms. You know, you have the medication, how what signs to look at and all that stuff. I've anecdotally been hearing that when patients do have a, you know, adverse reaction and perhaps are, you know, bleeding a little bit more heavily or actually, you know, are negatively impacted and they do show up at emergency room fearful of saying what medication they took, that it was miscarriage care or abortion care, and really kind of leaving emergency med providers to put the puzzle pieces together and figure out what's going on.
Great
Um,
news is that you don't actually need to put those puzzle pieces together because whether someone is bleeding from a spontaneous miscarriage or an induced abortion, the management's the same.
and that's incredible. And just to underline one thing, I think there's a lot of conflation around these two words as well is miscarriage care and abortion care. Abortion is miscarriage care. Like
It's so confusing, right? Because so in the medical field, right, we use abortion to mean the ending or loss of a pregnancy. And so that could be a spontaneous abortion, an induced abortion, a surgical abortion, a medical abortion, a threatened abortion, an incomplete abortion, an inevitable abortion, right? Like we just use the word to mean that a pregnancy is ending. In like terms, people use different words, right? They use abortion only to mean an induced abortion, and they use miscarriage to mean a spontaneous abortion. And then you get it even more confusing when you look at state laws because they'll say, oh, an abortion is when you do a procedure or take a drug or use a device to end a pregnancy, but it's not an abortion when it's for miscarriage or an ectopic, as if you can just like carve something out and say it's not the thing that it is, right? If you end a pregnancy that is ectopic, you've still ended a pregnancy, you know, that is technically, but in the state law it says, but that we're not calling it an abortion, so it's not an abortion. And so the difference between using the word medically and colloquially and how it's used is very confusing. And so, but yes, you're right. All the care is the same. If you have a uterus and a vagina and there is bleeding, you should examine it and figure out the source of the bleeding and manage it appropriately. That's the end.
yeah, absolutely. And when you are having these conversations about this type of care with emergency med physicians, are you seeing, you know, people of all genders showing up to this conversation? Are you seeing, because a lot of the underlying, I think, mission of feminem is, you know, gender equity, and how we look at that care. Um, you know, how are we seeing representation in these conversations?
Yeah, so femInEm has multiple kind of goals and objectives. And so certainly part of our mission is to improve gender equity in emergency medicine. But our objective of improving reproductive health care in emergency departments is not tied to gender equity in the profession and is meant to be aimed at any and all ED docs. And, you know, statistically, a lot of the medical directors that we speak to are men. And we talk to them and we say, this is what we want to provide in terms of education. We'd love to come to your department. And they're excited, right? Like, people want to provide the best care for patients. And if they know, like, hey, if I treat a patient's miscarriage better and they're going to have less bleeding and less chance of needing to come back to the emergency department, that's better for my department. It's better for my docs. It's better for my patients. And so at the end of the day, I think we often think of women in medicine as treating reproductive health care. But in this regard, it is all comers who are excited to learn about this and to implement it.
Wonderful. And for anyone who is watching this recording or, watches it later, if they are like thinking, wow, this would be great for my residency or, my fellowship, whatever it might be, my, emergency department, I want to bring this. How can they go about that? Just going through the website?
Yeah, they can go to feminem.org and click on the request a presentation button, and they can request us to come and give our grand rounds.
You guys make it so incredibly easy. And I guess really that makes me kind of think about where are we at with reproductive care at the training level, with PGY1s or, emergency med is 3 years residency, I believe. Um, are they getting a lot of training in this?
Yeah, so, ER training is 3 to 4 years, depending on the program. It's kind of a weird thing where there are 2 different lengths of programs. Um, and, we get trained on managing limb and life-threatening emergencies of all shapes and sizes, and so, yes, we learn about taking care of miscarriages and taking care of patients who are having vaginal bleeding or, an emergent delivery. That being said, a lot of people are probably still receiving the education that expectant management is the best or is at least, acceptable management for pregnancy loss, and it hasn't been updated to reflect what we know, and so that is part of what femInEm is doing, right? Like, so we're going to training programs, like, I was just at UVA in January so that they are getting the up-to-the-date, content, Derek Cass, who I work with, she's going to Roanoke later this month to do the same. I'm going to St. Louis in May. And so we both go to training programs, but then also to the community because training programs only represent a small number of practicing physicians in the country. And so it's important that we get them kind of wherever they are.
Okay. Well, I love hearing just the reach that you guys have and how you really are going to these, providers who are going to benefit greatly from this resource. I think taking a step back, thinking about femInEm and how you all are, you know, ensuring this education continuation and really empowering these providers, what what's the responsibility of physician groups? When there is legal ambiguity shaping clinical behavior, how are they responding to this? We mentioned ACOG, I believe that's American College of
Obstetricians and gynecologists.
yes. Thank you so much. It's a mouthful. And there are so many acronyms in the health policy and healthcare space that it drives me crazy. Um, are you seeing them, you know, kind of supporting their physicians by communicating what they're able to do, what they're not, or, how are you seeing those entities react?
Yeah, I mean, it's been interesting. So you've got ACOG who supports the OBGYNs. In emergency medicine, we have ASAP. Um, and it sucks that, like, reproductive healthcare has become so politicized because at the end of the day, it's just healthcare, right? We are not talking about some really far-fetched thing. We are talking about providing routine healthcare, emergent healthcare, life-saving healthcare, just like anything else that we do in the emergency departments. But because it's been politicized, um, some of these groups have been less quick to step in and protect their docs. But ultimately, what we need to see from them is a strong stance that protects docs and protects our patients and protects us and our ability to provide the care to our patients they need that we've spent so long training for.
Yeah. Yeah. I mean, having those groups and organizations, one, reflect what is the live experience of providers, I think is incredibly vital. I don't unfortunately see that in a lot of the different specialties, but having these organizations support their physicians through guidance, advocacy, and, just collective action is, I think, really important. Um, just, to round out the conversation when it comes to feminem, aside from having you all, come speak in person, have a presentation, can you talk about some of the other verticals within the organization where there, perhaps like a journal club or, other ways that feminem is supporting providers on the ground?
Yeah. So we talked about our education strategy, right? And so a lot of that is state based. So kind of the way it works is that we get funding to come into specific states and then we target every emergency department in that state to provide them this information. We also have kind of our just more broad grand round structure where we come to any ER, any training program that wants our lecture and we'll give them the training as well. Um, Separately, we have all of our gender equity work, right? And so a big part of that is our RAFs program. Oh, Asia is watching and she's gonna judge me because I can't tell you. It's advancement fellowship. I can't remember all the letters. But anyways, it's essentially like our women's group to support women in emergency medicine because there's something so important about community and helping you just advancing your career, but also supporting you like in your personal life and just juggling everything that it is to be a woman in an emergency medicine. And so that's a lot of our programming. We are working on some retreats coming up in the next year or so. So that, oh, resources. Thank you, Asia. Resources, advancement fellowship, and T is for, she'll tell us. Um, it's not training. Um, Anyway, so yeah, so that's a big part of it. We go to national conferences and talk. Oh, and team. That's the last T. That's T in Raft. We go to national conferences and give lectures to kind of try to target as many ER docs across the country as we can in one place. We also do research. We also help with clinical implementation of different protocols. So we've helped an urgent care in Michigan launch a medication abortion program, which is incredible. That was in a community that lost its abortion clinic. And so in 250 miles every direction, there was no abortion care. And they were like, we have a clinic, like we'll just start doing abortions here. And like how amazing, right? To step in and to provide that service to their community. And so now we work with other urgent cares who are interested in integrating medication abortion into their clinic protocols. Or trying to get birth control in emergency departments. I mean, even some emergency departments are integrating medication abortion. And so we also work to support those kind of systemic changes.
And I'm thrilled to hear that getting birth control in emergency departments is an initiative that y'all have. Um, in the South, we're seeing legislation that perhaps gives pharmacists or, I mean, perhaps providers. I think we're now seeing it more at pharmacists where the medication is being dispensed, them feeling some conflict of their beliefs versus patient care, which
Yeah.
I don't know how you juggle how someone would juggle that, as, a PharmD, but we're seeing a lot of that as well, so kind of taking that off, the plate and just having them in emergency med is incredible. As an anecdote, um, I have another friend who was going through her obstetrics residency and during her 3rd trimester, I mean, throughout the whole entire gestation, you're being asked to hold the same hours, sometimes if not more, because of that social unsaid pressure of, "Well, I'm about to go on maternity leave. I need to really, like, do my get my, night shifts in now or whatever before I leave." You know, there needs to be that conversation about how we look at pregnant providers in emergency med and what we're asking them to do. And
Or I feel like I just need to hire you as our feminem cheerleader because I completely forgot that that is one of our other programs, right? Is model policies, and those will be coming soon. And that's exactly right. So in advancing gender equity, we have to have policies that support resident or women throughout their emergency medicine careers. And so that means, like, what does it look like to support someone who's pregnant and in resident or and is an ER doc, right? Like you said, no night shifts. Like night shifts are shown to increase rates of miscarriage, preeclampsia, preterm labor, having a small for gestational age infant. And so we know that night shifts are harmful. But that pressure that you mentioned that, like, people feel obliged to work more night shifts separately cannot is not acceptable, right? Like, you should not be punished because of this physiologic reality, and so we have a model policy that we will be sharing that, both addresses pregnant people not being asked to work night shifts during the 1st and 3rd trimester, but also not being forced to make up those night shifts at a different period when, docs come back from maternity leave and they are pumping and lactating, like, what does that look like to support the lactation, and kind of the breastfeeding experience postpartum while allowing them to also to return to work and be an ER doc? What does it look like for both parents, right? Whether you were the birthing parent or not the birthing parent, what does it look like coming back to work after the birth of a newborn? What does it look like to support ER docs who are in their 50s and 60s? Like, should they still be working night shift? What's the best, policy there? And so we are looking at what model policies can be to support ear docs throughout their careers.
I am nothing if not the biggest fan of people who look at the systems that we have been operating in from like the 1800s and recognizing that it's not serving anyone. Even if you're not a pregnant provider, if you are the partner of a pregnant provider, you also are missing out on that time with your new child. And so much of the work that I do is looking at the systems that have not been serving anyone for who knows how long, but we just really haven't had the bandwidth to look into it or perhaps the resources. And now taking the time to be like, hey, this system of residency that we created that only allowed males originally to be in
Mhm.
100% on extracurriculars and having them do these hours and having now, it's not helpful to the providers. It's not helpful to the patients and to patient care. Patient outcome absolutely suffers when the provider is not performing at their top ability because of preventable reasons. So we honestly probably will have to have a second Substack live about it because it's something I recently started to really look into and understand and have faced myself personally. Um, as I've supported my partner. So, we're at about time, but there's one thing I always want to emphasize in my conversations, in my content, is that there are so many things happening that seem very regressive and are very regressive, but how are we keeping the hope alive? What actions can we do? So before we close out, something I ask everyone, what's keeping you going and giving you hope these days in the reproductive space?
Let's see. I mean, I live in Virginia, and we are looking at a constitutional amendment this fall to protect rights, reproductive rights in our state. So that's very exciting. But really, just like the work through femInEm and going to these ERs and teaching these docs and seeing how receptive they are and how excited they are to improve the care for patients, like knowing that there are just docs everywhere in this country who wanna do the right thing and who now are empowered to do the right thing, and the patients will be getting better care because of it is really, really, hope-inducing.
Yeah, I love that. And that's a large part is the people for me. It's what keeps me going, getting conversations like this. But Kimberly, thank you so much for such an important conversation and really illuminating a lot of the things that are impacting access and how we discuss these topics. I think it's easy to think of policy as something that lives far away in Washington or courtrooms, but as we talked about today, it shows up in emergency departments, funding decisions, and in moments really when patients are seeking care the most. So thank you for bringing both your legal and clinical lens to this conversation. I genuinely appreciate it. Thank you to everyone who spent your hour with us. If you have any follow up questions, drop them in the comments, and this will be probably cross-posted by both our platforms later on. So thank you so much for your time today.
Thanks, Laura. It's good seeing you.
Bye.